gears, next slide, and provide you with a update on what are the important coding changes for 2021. And indeed, change is here. Next slide. I like to call this transitioning to tomorrow, but to a significant extent, tomorrow is January 1st away. This is an initiative related to CMS moving to lessen all the administrative work we do. It's patients over paperwork. The definitions have been released and published in CPT 2021 with an implementation date of January 1st. And this is after final CMS approval and publication. Next slide. An overview, what changes, what stays the same. Staying the same is the overall concept of medical decision making. The providers have to establish the diagnosis. It's in the levels we know, straightforward, low, moderate, and high complexity. And it's based on problems, data, and risk. Medical necessity will still be the determining factor for code selection. What's changing applies only to 99201 to 205 and 99211 to 99215, our office visit evaluation and management codes. The code selection will be based on medical decision-making or total time. And there will be new guidelines for medical decision-making. Next. So the changes, again, office visit codes only. There will be a future look at other evaluation and management codes, but the office visit E&M codes are the focus for this year. There was a previous proposal out there to blend office visit codes, and that's been deleted. So you can absolutely erase that from your mind. There will continue to be separate payment for 5 levels. You will note that 99201 is deleted. As they applied the new definitions and requirements, it was clear that 99201, a very minimally used code, would not be necessary. As part of this, there is a resurvey of the relative values, and this, of course, relates to payment, and I'm going to talk about what we anticipate in a later slide. Next. So the change again, elimination of history and or physical examination to determine the code level. Yes, you still need an appropriate history and exam for the problem you're seeing, but it is not necessary to overdo the history and physical component because it will not be determining the level. Time or medical decision-making will be making that determination. When we talk about time, it's both face-to-face and non-face-to-face on the day of the encounter only, and it does not include clinical staff time. Next. You can run through the animations on the next 2 slides, please. So where we are now, key, history, exam, medical decision-making. Next. Contributory counseling, coordination of care, nature of presenting problem, and then next, time. Next slide, please. So this is where we're going. Key, medical decision-making and time. Contributory, now seeing history and exam have moved down to a contributory factor with counseling and coordination of care. Next. Medical decision-making in 2021. I say changes here, it is indeed here, but more will be coming in the future as they look at other E&M codes. This is today transitioning to tomorrow. It's medical decision-making on overdrive, and it's where you need to focus your attention. History and exam will be the least of your concerns. Next. Medical decision-making is more straightforward. It's in a single table with levels, straightforward, low, moderate, and high complexity with 3 key elements: the number and complexity of problems. This used to be diagnoses. What we know now is it's going to be problems, which fits better. Often when we see patients, we don't know the diagnosis, but we do know the problem. The amount or complexity of data reviewed, and the risk of complications of morbidity or mortality. Next. These are the three elements of medical decision-making and the additional words that have been added and are official. So we look at problems addressed, data to be reviewed and analyzed, and risk of patient management. Next. Medical decision-making, when we look at types of problems, are as they have been, from minimal, self-limited or minor, acute uncomplicated illness or injury, acute illness with systemic symptoms such as lethargy, fatigue, undiagnosed new problem with uncertain prognosis, chronic, stable, or with exacerbation or progression. And stable is defined as a patient who has not yet reached treatment goals. Acute complicated injury, or an acute or chronic illness or injury posing a threat to life or bodily function. Next. This is the slide that says it all. And this is one I am going to encourage you to spend some time on in the future looking at, because this is the official summation of what we're talking about. I looked at this and I thought, oh, this is way too much. I am going to simplify it. Next slide. This is the Tuck simplification, which includes a lot of the key elements you need to be aware of. And I'm just going to take a minute to walk through this. To the left column, you'll see the E&M codes, and you will notice that the new and established perfectly crosswalk. This was not true in the past. There was difference between new and established. Not true now. The time elements are also listed in a range for each of the codes. The problem column, problems addressed, goes from one self-limited or minor, which could be a diaper rash, a URI, to, for a 213, one acute uncomplicated illness, might be where an otitis media would sit, straightforward. 99214, one or more chronic illnesses with an exacerbation or progression. This could be an asthmatic who is wheezing. And a 99215, a chronic illness with a severe exacerbation. So this would be that asthmatic who comes in and gets the full court press, is hypoxic, wheezing, gets multiple aerosols, oxygen, you send him home on antibiotics with steroids, close follow-up. The next column, data reviewed or analyzed. And here is where auditors are going to want to look, because these are defined with numbers. So we have no necessary data until 213. And there we have two categories, 1 and 2. Here you need one of the two categories, and you can use any combination of two for category 1. Reviewing an external note, reviewing a test, ordering a test. This is each test. Now a test, if you order a metabolic panel, is everything in the metabolic panel, one test. If you order a CBC and a SED rate, that is 2 tests. It's defined by the CPT code for each test. The same is true of reviewing the results of each test and reviewing each external note. In this category for 213, you will notice category 2 is apparent history. History from other than the patient, which could be a guardian, a grandparent, another source. You can meet 99213 by just getting a parent history. 99214, you'll notice that parent history moves up to category 1. So it doesn't help you quite as much as it did before. Category 1, tests as above, and parent history. Category 2, interpretation of tests by another physician. And category 3, discussing management with an external physician or source. Here you need one of the 3 categories. 99215, you need as the 214, but you need 2 of the 3 categories. Moving over to risk, this is morbidity and diagnosed and test management. Minimal, low risk, moderate risk 214 examples. Here is where writing a prescription helps support a decision on minor surgery, elective surgery, and here I'm very pleased to show you diagnosis and treatment related to social determinants is now a counted element. For a 215 level, high risk, one of the important messages is that if you consider hospitalization, you are going to meet that highest level. Just considering hospitalization, whether or not the patient progresses to that. Next slide, please. Let's go through an example. We have an 8-year-old patient with a diagnosis of morbid obesity being seen for reevaluation. An interval history is obtained from the mother and a focused physical exam is completed. The patient's weight has increased excessively and there's been poor compliance with dietary recommendations. The decision's made to proceed with nutrition counseling with a dietitian. Follow-ups planned on a monthly basis. Next. Here, this is how it fits in the grid. We have 99214 problem level moderate, 1 or more chronic problems, obesity. Data input from the dietitian has been sought. Risk low, we're changing the diet and we're going to do repeat weight checks. This meets the level of 2 of the 3 elements met or exceeded and gives you a moderate level of decision making. Next slide. So medical decision making documentation becomes very important. And these are elements you need to think about. Remember, you need best 2 of 3 of the elements: diagnosis, data, problems, and risk. So we look at first the amount or complexity of data. Note if you reviewed the patient's chart or obtained history from someone other than the patient, the parent. It has to be documented. Discuss the case with another healthcare provider. Note if you intend to order old records. Note if you personally reviewed a specimen, an image, or a tracing. Note if other diagnostic test results are there or ordered. Number of diagnoses. Note any workup planned. Note comorbidities and complications. The status of a chronic problem or prognosis. And risk. Note the decision-making level of risk. If you do prescribe, and that will be obvious in the record, and note social determinants of health that are inquired about or addressed. Next. These are medical decision-making clinical examples that fit within this framework. And as I mention these, I want to qualify it because these are gray. They aren't always just clearly defined right on the mark as I'm talking about them. So you can see, for example, otitis media, which would be typically a 99213, push to a 99214 based on additional concerns, a chronic problem that's addressed because it's repetitive. Otitis media with fever, lethargy, vomiting might be a 214. Asthma, as I cited in going through the grid, straightforward would be a 213 with persisting cough. Asthma, wheezing, low O2, treated with an aerosol home, 214. And then the asthma acutely ill patient where they are on the verge of being hospitalized and you consider it a 99215. Next. Time. Remember, I said medical decision making or time. Now, when we think of time, we think of total face-to-face time when counseling and coordinating care constitute more than 50% of that face-to-face encounter. Next. Time. Next. Time. Now. These are the elements, and I have told you in the past to have these tattooed on your arms. If you did that, you are going to need to get a laser out and remove the tattoos. Next. This is time in 2021, and you will see they are in ranges, and they go from 99202 of 15 minutes to 60 minutes for 99205. So the time elements are more. Next. Established patient E&M codes, time 99212 to 99215, 10, 20, 30, and 40 minutes. Next. Prolonged services have changed in that there is now a new code, 99417, prolonged office or other outpatient E&M service each 15 minutes. So that would be added to that highest level of time in either the 99205 or 99215, but has to be carefully documented. Next. We need to talk more about time. It is the day of the service only. It includes preparing to see the patient before you go in, reviewing tests, records, counseling and educating, ordering medications, procedures, communicating with other healthcare professionals or the teacher or the counselor, documentation in the EHR or other record, and interpreting results, communicating with the patient or family, and care coordination. So now when you see that child with the father, but the mother wants to be called, and you make that call later and discuss it with the mother, that time counts if you are going to be coding on total time that day of the service. Next. E&M payments related to the office visit codes are so important. And I bring this up because pediatricians still undercode. The difference between a 99213 and a 214 is 50% more. And to a 215, an additional third or 33%. It is significant. Next. This shows how we are expecting the new codes to translate in terms of relative values. The relative values are actually much higher than these percentage increases, but what is projected to decrease significantly by almost $4 is the conversion factor. So payment for Medicare is relative value times the conversion factor. And you will see for the established office visit codes, we can expect some nice increases. For the new codes, the same or some decrease at the lowest level. There is certainly pressure on CMS to maintain healthy reimbursements for these, and I'm hoping we see more than this, but this is what is currently projected. These new relative values and the conversion factor will be officially published at the beginning of December. Next. So what about the current and the transitioning process? Problems, as we've talked about, acute, chronic, and an injury, and these are important to the level of care in all locations. Testing referrals that are ordered, interpreted, and discussed and documented, key to medical decision making. Remember that before and after visit work are, in the case of coding for time, included in the total day of service time, and it may be appropriate for prolonged time. The other work would be separately considered: telephone calls, telehealth, virtual care. Next. This transitioning process, as I mentioned, involves the new relative values when they're published and the payer considerations with acceptance. And this relates to your contractual relationships. It relates to working with CMS and Medicaid in Ohio to get this recognized. As I mentioned, private payers, and the question, what are going to be these payments? And I've showed you what we're projecting. What about payer adoption of these guidelines? Payers have been hearing about this for a year, but I know from our last Pediatric Counsel meeting, when we talked about it, it was like having deer in the headlights. They didn't seem to know that this was happening, and we're hoping it was the group we were talking to and that there are others more knowledgeable. But to be HIPAA compliant, payers have to recognize these new guidelines January 1st. They might continue to accept the old guidelines for a period of time, a grace period, but they have to accept the new guidelines. Next. The transitioning issue for you is to consider your EHR. There have been many modifications to EHRs in the past and coding assists. These have been focused on history and physical examination because they've been the easiest to cut and paste and use bean counting. What electronic health records need to do now is to do ease and prompting of medical decision-making and look for enhancements for documenting total visit time. Some EHRs will now document face-to-face time, but they can't capture the before and the after. So there has to be a tool for that. And just a statement given as to the total visit time for the day in minutes is adequate, realizing it might be somewhat of an estimate. Billing and office management systems will also need modified. There are care management codes that have unique requirements that are monthly codes based on 20 or 30 minutes spent during a month. So there have to be issues considered with those. Bottom line, contact your vendors, see what they're doing about this because they need to adapt and to help. Next. One last thing. This is my slide, which shows preventive medicine, gold standard, right futures guidelines, and what you should be billing in addition to just that preventive medicine visit. And what I want you to focus on is the bottom line, immunizations, Immunization Administration. And I have a great announcement. Next visit, next code, next slide. And that is a great victory for 2021. And that is that Immunization Administration codes, which have been decreasing in value since 2017 for not very good reasons, are expected to increase dramatically to values shown here higher than 2017. So look for this. If you are getting paid by relative value, and some companies such as Anthem are doing this, you should expect to see an increase. This does not relate to the VFC program, which is its own unique animal. This will prompt and provide information to work with VFC to get administration increased, but it will not be as clearly accomplished as working with private payers using these relative values. Next slide. Resources for you. You have a superb AAP Pediatric Counsel chaired by John Price. And I encourage you to get questions, problems you might be having, not with individual patients, but when there is a problem with a payer that is repetitive, get that information to the council to work on. The section on administrative practice at the Academy is excellent. SOPM, private practitioners, you should be involved. Great website, email chat, which at times gets taxing, but is on the cutting edge. We have a National Pediatric Advisory Council, and there's a Pediatric Practice Managers Alliance under the umbrella of SOPM. Go to aap.org and you can access a myriad of practice-related resources, many related to the changes that are coming in evaluation and management codes that I've just talked about. Next. The most important coding connection for you is AAP Coding Hotline at aap.org. You can get information on specific coding issues, everything including information related to these changes. The coding publications are also excellent. Coding for Pediatrics this year has all the changes I just talked about, with many more clinical examples. The Pediatric Coding Companion is there. There is an ongoing pediatric newsletter, which has been emphasizing every month the medical decision-making coding changes with examples. There's an RBRVS brochure. If nothing else, look to AAP News and the Coding Corner, which is a very brief, concise update on changes that are coming. Next slide. I'm sure there are more questions than we can answer. This was meant to be a prompt to you to provide you with some concise information. Because of the way our morning is constructed, I don't see that we're going to have time for questions, unfortunately. But I do want to call your attention to two upcoming opportunities. John Price is going to talk about this in more detail in a webinar on December 9th. Be sure and be there.